a right tympanoplasty. Originally we had tympanic membrane perforation with on an atrophic tympanic membrane with a retracted tympanic membrane at the posterior superior part of the tympanic membrane, and but clearly controlled, stable, and you can see here the stapes. So this is 12 o'clock, 3 o'clock, 6 and 9, and we have, and this is the reason why I thought it was interesting to put that online. We have this adherence between the tympanic membrane and the stapes head with the eastern facial nerve here on the left. And so I'm going to dissect the stapes head. And then, of course, I intend to perform ossicular reconstruction with a TORP. Could be also with PORPs, but as you know, I prefer using TORPs. But the most important thing here is to separate the stapes from the tympanic membrane, which is not easy because we have a mobile stapes. So I need to find some, not cleavage plane, but plan of dissection. Calmez s'il vous plaît. So we need to use different types of instruments trying to separate this tympanic membrane retracted to the stapes head, the myringostapediopexy. There we go. And of course I need to do it very gently because I don't want to perform a dislocation of the stapes. And also on the other side I don't want to leave any skin. Ciseaux. This is mucosa, but I'm going to cut it. Okay, I've already taken perichondrium graft to reinforce the tympanic membrane posteriorly, and I will do that at the end. Now I think you see the dissection is done. We have an eroded incus here, which is separated from the stapes head. So of course I will remove the incus and put a prosthesis, but first we need to dissect the malleus. Table en avant, s'il vous plaît. Stop. So I need to separate the malleus from the tympanic membrane now, in order then to get the malleus, because I want to use it, of course. There we go. Undo, s'il vous plaît. So there was a bleeding a little bit here, which is making some trouble. Pouvez vérifier, s'il vous plaît, pour la tension. But combien? Okay. So here is the malleus handle, which is a little bit, definitely really anterior. It's overlying the fistula anterofenestrum. So there is a big gap, and of course I want to reduce the gap. As we have a really atrophic tympanic membrane, I'm going to use a very small suction tube, and not 1.2, but I'm going to use 0.9 because I don't want to make any tear, if possible, at the anterior superior part of the tympanic membrane, because I just need to reinforce the posterior part of the tympanic membrane. You see this bleeding even when I dissect the malleus handle. We have some kind of bleeding. It's a good thing. Of course, the incus is not anymore connected to the malleus, to the stapes head. So this is then easy to dissect the malleus handle. So I'm following the bone like this. You see the distal tip of my instrument, which is bent. Oh, the elbow is always a problem, but specifically in this case. All the posterior part of the drum is really atrophic. And there was a posterior inferior perforation. But I want to preserve, if possible, the residual tympanic membrane. Otherwise, I will have to take a second part of the perichondrium from the tragus. You can see how medialized is the malleus handle here. So by repositioning the malleus, we will solve the problem of the medialization and put a TORP on a good position. So we have a situation here related to this tympanic membrane which is not so good. You see how difficult it is to dissect this part. Okay, I think it is better now. Yes, definitely it's good. I will check the tympanic membrane after, but I need to continue the dissection because I need to dissect the neck of the malleus now. And I think it's nearly done. Les manches du marteau. There we go. Here we go. It's nearly done. We have a little bit, I think, of adherence at the level of the neck here. We need to be sure that we have entirely separate the malleus from the tympanic membrane before relocating it, otherwise you make a big tear in this case. We have some adherence here anteriorly. Okay, it's gonna be fine. Okay, now I can remove the incus. Causse Ear, s'il vous plaît. D'abord la curette. I need to increase the body resection, I think. I will have some trouble to remove the incus. And also, if I want to relocate the malleus, I think it's better to have some gap between the bony canal wall posteriorly and the malleus handle. Causse Ear. It's not so easy to remove the incus in this case because the bone is thick of the bony canal. Causse Ear. Pince encore. So we need to do that several times until Causse Ear. You see the bone here, maybe I have to remove the bone from here a little bit more. Difficult, so curette encore. I cut the chord tympani because we had some epidermal ingraft connected to the chord tympani, so I had to sacrifice the chorda. Okay, let's try again. Causse Ear. Otherwise, you know, the other option would be to push the incus in the attic, which is not making any trouble. If I cannot remove it, I will do that. Pince encore. The only thing I need to remove it or push it because I want to relocate the malleus, and to do this we really need to have you see how difficult it is. Causse Ear. Particularly difficult in this case. It's gonna come. I think there's a lot of fibrous tissue also. This is the residual chorda. This place, which is There we go. Right, okay. So now I need to cut the tense tympani tendon. Lancéolé direct, and then I will check the tympanic membrane. Alright, now I'm going to relocate the malleus, causeus. Going to bring the malleus back posteriorly, like this, overstretching the arterial ligament. There we go, and that's it. And now you see, you notice how I was able to reach the resistance of the anterior tympanomedullary ligament and to overstretch it. Okay, at the moment it's fine. I need to check the tympanic membrane now. Can we? Alright, it's fine. So this is the atrophic part, and there's a perforation here which I'm going to close with the graft, but there's no need to take a second part of a perichondrium, a second phase, because it's fine. Alright, good. So the next step now is to determine the prosthesis length. So I need to measure the distance from malleus to footplate. Causeus. So first I need to place the malleus in a correct position, about the level, over the level, overlying, I mean, the footplate, the stapes footplate. And now I can measure. Mesureur. Alright, I need to cut the stapes tendon, of course, in a second, but now I need to measure the distance. Okay, that is fine. So we are between 5 and 6. 5.5, which means that 6 should be okay. Let me see if the malleus is fine. So I will stick the malleus or the tympanic membrane back to the malleus handle to be sure that it's not going to be too short. That's fine, I think. Encore le crochet, s'il vous plaît. I think a little bit more, maybe. Let me see if I can. I like to stick it like this to the tympanic membrane, and then I know that it's going to be better now. Mesureur. But I think it's the right length. 6 should be okay. So you noticed I measured 5.5, and I always at 0.5. So 6 should be okay. Alors, les ciseaux, s'il vous plaît. So now we need to cut the tendon, because I will use the Silastic bending technique. There we go. And set, s'il vous plaît. Next step will be to place the graft, and the prosthesis placement is at the last step. I need to remove some kind of fibrous tissue overlying the footplate, so I will have a better view in order to expose more the footplate, because I want to be sure that I'm going to place the prosthesis shaft, the shoe of the prosthesis, precisely and efficiently. That we go. I think now we can see the. Pouvez me le changer, s'il vous plaît. Now we can see the footplate and set way. Now you see the footplate in the deep, so it's fine. I don't need to see more. So now that's fine. Everything is ready. I just need now I need to place the graft. Canne les manches du marteau. So I took a perichondrium from the medial side of the trachea. I like to use this type of material, and I will put it over the bony canal wall and over the malleus handle also. So I elevated the flap, the tympanomeatal flap from something like 5 o'clock till 1 o'clock. This is 5 o'clock. So you see the annulus is elevated there. Okay. All right. So let's place now the graft. À 12. Okay. So I want to stretch it correctly. I want to place it over the malleus handle first, which is even more easy here because I relocated the malleus, which is now more posterior. And I need to place it over the bony canal wall, as you can see. Now I need to place it inferiorly to cover the inferior angle. So I'm going to place it over the bone, and that's enough, I think. Alright, and now I will reposition the flap. You see the annulus. So this graft is running over the malleus handle and over the bony canal wall. And I'm reinforcing the whole posterior half of the tympanic membrane. That's enough, especially because, of course, I use the prosthesis, and the prosthesis head will be in contact with the posterior half of the tympanic membrane, which was too atrophic. So although it's a hydroxyl apatite head prosthesis, which is a very biocompatible material, I believe that if we have a really fragile, atrophic tympanic membrane, it's always better and safer to reinforce it with a graft. Okay, now it's fine. So what I'm going to do now, I will re-elevate the whole flap, and we are now going to perform the ossicular reconstruction. The last step. So you see the malleus is no more medialized, and now we need to prepare the prosthesis. Okay, so I'm going to use, as usual, the Vincent-Grace HA-Titanium TORP. I'm going to cut it at 6 mm, which means that first I need to push it up to 5 and then pull it back, coming back to 6 after having cut the proximate part of the titanium shaft. There we go. And pull it back to 6 mm. There we go. That passe. Okay, it's nearly done, so I'm going to place the prosthesis now. Okay, we need to place the shaft. Vous me changez d'aspect s'il vous plaît. I need to change the sucker. So we need to place first the shaft, the shoe of the distal tip of the shaft. I don't care about the position of the malleus at the moment, or also the stapes. The only thing is placing the shoe like this and being in contact with the full plate. Now it's done. Okay, you can see that. Okay, next step now is to introduce the malleus within the prosthesis head, the groove of the prosthesis head. You see the malleus is there, so I will rotate the prosthesis in order to place the groove parallel to the malleus handle. Rotating it like this, and then grabbing the malleus, causse, grabbing the malleus and placing it within the groove. So now you see it fits very well. And the last step now, of course, is to to attach the prosthesis to the stapes with the bend, in order to ensure a better long-term stability of the TORP. So, as you know, when you do this, there is always a risk of dislocating temporarily the prosthesis from the malleus handle. That is not the case, because then you can reposition it. But here it was fine, and now I think the position is pretty good. We have a nice contact here between the prosthesis shaft and the stapes, and you can see that they are moving together, which I think is really good. So what I'm going to do now, I will reposition the flap and see if everything stays in place. It's an important step, because the key point is that if the prosthesis is too long, when you do this, you can see that the prosthesis is moving backwards posteriorly, I mean. But I don't think it's the case. It stays in a nice condition. You see the contact between the tympanic membrane and the malleus. I'll show you this. You can see a nice contact between the malleus handle and the tympanic membrane, and a nice position of the prosthesis. So it looks good. That's it. I just now reposition the flap, definitely, and it's okay with me. I will put a mirror cell, and that's it. Mirror cell. Allez-y. Alright, thanks very much for watching. I think the interesting point is that this dissection that we had to do between the retracted tympanic membrane, which was very thin, as you noticed, attached to the stapes head, and then of course the residual surgery is the one you know, but I think the dissection was more interesting. Thank you very much again. I hope you enjoyed it, and see you again soon. Bye bye.